Hello, and welcome to the Society for Healthcare Strategy and Market Development's interview series on innovation and disruption. We're interviewing some of the leaders in our field that are bringing practical ideas that have immediate impact. We're going to be talking about topics such as the future of work, innovation and disruption, scaling change, and engaging patients and providers in new ways. We have a series of interviews, and we hope that you enjoy them. My name is Craig Allen Aarons, and I'm your host. I'm a managing director with Anchor Consulting, and today we're interviewing Dr. Sachin Jain, who is president and CEO of Caremore Health, an innovative delivery model that focuses on low-income seniors and low-income populations. He has recently come to the stage as one of the most influential leaders in healthcare. In fact, Modern Healthcare recognized him as the 36th most influential person in healthcare today. He is a contributor at Forbes on healthcare. He is co-editor-in-chief of the Healthcare, the Science of Delivery and Innovation, and an adjunct professor at Standford University School of Medicine. So what do we hope to learn today? I hope that you as a listener learn about new innovative care delivery models that are disrupting markets. Learn about how rideshare can positively impact and position your healthcare institution in order to better serve patients. And I'm hoping that you'll learn about ways that you can be inspired by leaders such as Sachin to take ideas that are not the norm for healthcare and apply them in a practical way. So I hope you enjoy the show.
So I'm president and CEO of the Caremore Health System. We're a wholly owned subsidiary of Anthem Incorporated. We sit within what's called the Diversified Business Group, which is really the non-health plan businesses of Anthem. Caremore did have a health plan until recently, but we've pivoted and we're recasting Caremore now as a fully delegated medical provider that really focuses on frail and vulnerable populations and high-cost, high-need patients in particular. So we have our roots are really in senior care. We take care of about 90,000 seniors nationwide. And then we also, over the last several years, have diversified to take care of about 60,000 Medicaid beneficiaries in what is now a 6-state footprint. 10 in total, including our Medicare delivery model. I came to Caremore really because there's a real paucity of healthcare organizations that are trying to really segment and take care of sick patients differently. And as a clinician, that was something that I always thought was important is that we need to apply different levels of intensity of clinical service to patients who had more intense needs. And, the traditional American healthcare model really treats everyone the same way. All patients get a 15-minute appointment, whether they need an hour-long appointment or a 5-minute appointment. And that just felt wrong. And Caremore, throughout its 25-year history, has been a leader in really sub-segmenting populations and really doing more for patients who need more. And so I was very attracted to that. And actually, left a position at Merck Incorporated as well as the Boston VA, where I was a practicing internist, to join Caremore, first as its chief medical officer, and then was promoted to be president and CEO a year later in 2016.
And Caremore's model, it focuses on targeted populations, whether it's senior or Medicaid. So there are two very different populations. And even within the senior population, you can even segment and try that population even more discreetly, probably. Can you talk a little bit about how you do that in the sense either from a data perspective, a care model perspective? How do you make it work, and how do you provide value?
It's a great question. I think one of the big sort of challenges in our industry is I think we tend to think about high-cost, high-need patients like they're a fixed category of people. The reality is that everyone who's healthy today will at some point in their life likely become a high-cost, high-need patient. And so, when we say we're a high-cost, high-need patient, model, it doesn't mean that we exclusively take care of high-cost, high-need patients. It means that we actually take care of a full range of people But then as people's needs escalate, as the burden of chronic disease grows within a patient or a population of patients, that we ramp up the service intensity to match the needs of the patient. And so we both focus on delaying and slowing progression of chronic disease, as well as more effectively managing acute episodes when they happen. And so we actually have a model that embraces patients with an additional set of clinical services, an additional layer of clinical services above and beyond kind of the traditional services, which they also have access to, primary care docs, specialists, hospitals. We actually have chronic disease management care centers that are located in neighborhoods where patients live, as well as extensivist physicians who are embedded within the hospitals that we contract with and ensure a higher level of coordination of care in the inpatient setting, in the SNF setting, as well as in post-discharge follow-up. And so, what we're really trying to do is fill some of the gaps that in coordination that really happen across the continuum of patient care, which in the process lowers the admission rate, lowers readmission rates, and really takes a lot of cost out of acute hospitalizations for patients and for populations.
Okay, so it's not only on the front end in terms of the clinic kind of interaction and managing that relationship at the front end, but it's also the transitions of care that you spoke to, in ensuring that they get the appropriate care at the right time, the right place. It sounds like I'm summarizing correctly. Is that correct?
That's right. Yeah, and then the other piece of it, I think everyone today is talking about social determinants of health. We were, focused on that as an organization as long as we've been around, which is 25 years. We've always provided transportation to our members to get to and from their appointments. We think that's a huge barrier for patients with chronic disease to actually accessing their care. We've innovated over the last several years to focus on things like senior loneliness. We have a chief togetherness officer who operates a program that focuses on outreaching to our most lonely and socially isolated members. We provide post-discharge meals to patients who have been hospitalized but may not have appropriate foods or access to food in their home settings. So there's quite a bit of, I think, innovation that's happening around the margins, not just of clinical care, but also of the delivery models.
Right. So let's talk about that, because you recently co-authored an article on transportation. Tell us about that and what makes that so unique in terms of its findings compared to other systems of deliveries of care, and how it impacted the service to your population.
Yeah, I mean, we were the first, health plan in the country to partner with Lyft or Uber around using ride sharing to facilitate patient transportation. And we initially did it in a pilot, the results of which were published in JAMA, and subsequently have extended it to serve most of our patient population in partnership with Lyft, as well as ALC, which is a broker that we partner with as well. What we were able to demonstrate was improved quality, better on-time performance, reduced wait times, all the kinds of metrics, and improved member and patient satisfaction. For all the reasons you might expect. The reasons that people like Uber and Lyft more than traditional taxi and transportation services really translate nicely into a healthcare setting. The service qualities are better. Rides typically come from people who are close by to you, and so that you don't necessarily have to wait for long periods of time for a driver. There's a greater transparency of performance, greater transparency of kind of arrival and departure times. So it's been a big success. I think we're not resting on our laurels. We're now kind of working to actually build our own member-facing app right now. Rides are actually requested in a very senior-centered way through a central dispatch team that we have here at Caremore. But what we're doing is trying to put more power into the palms of patients and actually build a My Caremore ride app that they'll then be able to use to come to and from their appointments.
That's fantastic. And, a lot of organizations I work with, there's often a lot of barriers that are brought up in terms of the relationship of Lyft or Uber, in terms of using that as a service. I suppose you encounter the same barriers, in terms of, we can't do that because of X, Y, Z, or what happens if this happens, or with the patient in an episode of care happens inside the car. How did you overcome those sort of preconceptions and kind of the what I call the healthcare kind of initial resistance to anything outside of a more traditional model of a relationship?
Yeah, and I think it's a huge problem that we actually have within our industry. I think there is a bias towards conservatism, a bias towards kind of resisting new and innovative solutions and approaches. And so I think a lot of this is cultural, and these things either happen or don't, because organizations make a decision that they want to make them happen or not. So that's kind of my view of it.
Okay. Well said, and I think you're right. Culture does tend to breed innovation versus not. And so the provider side of the equation, your care delivery model, access is key, and no matter who you talk to in terms of caring for patients. They want to be seen, and they want to be treated and cared for in a way that a lot of healthcare systems aren't meeting right now, or plans aren't meeting for their members. Tell me how you enhance that provider model and provide access, and what makes care more different, for taking care of their patients. So how do you make what's the care more different?
I mean, a lot of it is the culture, I would say, and people don't talk about this because everyone says we care about our patients, but when you have a name like Caremore, you have a lot to live up to, So I would say that this is an organization that really did put patients before profit. This is an organization that still to this day makes decisions that go against our bottom line but are the right things to do for patients, and I think that sort of true north ends up changing how you think about just about everything. It's why we do invest in things that others would, look at as a cost center, on face value. So I think that there's the Caremore difference is decidedly a culture that is very pro-patient.
Okay. And when you say pro-patient, so I mean your staffing model is heavier, or do you have like a different kind of technology tool set?
We're a spend to save model because we're fully at risk for all of our expenses.
Right.
We are fully delegated for risk for the entire cost of taking care of these patients. We will make investments that have longer term returns. The average Caremore patient is with Caremore for 7 to 9 years, and that gives us a lot of flexibility to make longer term investments that people don't usually make in their patients because they're paid on a fee for service basis. We're paid on a globally capitated payment. That global capitation payment gives us very strong incentive to do right, not by the patients, not just what's right for them for today or tomorrow or next week or next month, but also frankly what's right for them for their entire lives.
Right. And so that being said, you need a strong understanding of and relationship with the patient, not only that relationship and front end part, but also the data that supports it technologically and from you said it at the beginning, segmentation perspective. What tools and data do you use to more effectively manage that relationship over the long term, whether it's consumer lifestyle data or what have you? And you mentioned social determinants. That's kind of like the buzzword right now, but it's really tell me if I'm wrong. Yeah.
No, I mean people people talk a lot about data because they don't actually touch patients, and so they're trying to infer things about them that they could actually know if they just asked.
Right.
And so a lot of our opportunities come from just listening to our patients and knowing our patients. That makes all the difference in the world.
Yeah. So it's
a good example of that is our loneliness intervention. So a lot of people would say, well, how would you use data sets to identify whether patients are lonely or socially isolated, and can you run a regression of their attendance at medical office visits against their total medical spend? I mean, you could do a lot of things to find out who's lonely and socially isolated. But you're never going to do as well as just asking the patient,
right.
do you have anyone in your life that cares about you, that you talk to on a regular basis? That turns out to be a very good question to identify whether people actually have social connections. And so, again, I think that's the power of being an organization that's both, that's highly clinical in nature.
And so, we've spoken a lot about senior care. A lot of our questions have kind of skirted around that, but we haven't transitioned over into more of the Medicaid segment of the population and its unique issues. And in my experience traveling and working with clients, a lot of Medicaid care is done by academic medical centers, in particular with training relationships, which is needed in order to advance medicine across the country and have new trainees learn. But it's not always the most ideal setting. So how is it that you manage that population? Is it similar to your approach with senior care but nuanced? Can you tell the audience a little bit about that?
Yeah. So what I'll say is, these are people. They're not training opportunities.
Yeah, exactly.
So we treat them with the dignity and respect that they deserve. We hire the best and the brightest. We give them enough time and resources and support to take care of the patient, and really try to give them access to the same kind of clinical quality and clinical experience that you and I would like. And we open our clinics from 7 a.m. to 7 p.m. 6 days a week. Those are the kinds of things that I think this population responds to. What we've been able to demonstrate is better outcomes when you actually make high quality care available. I think one of the biggest problems that we have is we do have a bit of a caste system in American healthcare, where different people, depending on their insurance status, get different quality providers. That's something that we are really working to rectify. And we just published our results in the Harvard Business Review blogs from our Medicaid pilot, and we've shown lower hospitalization rates, better quality scores. Those are the kinds of things I think that ultimately make a difference. And patients who happen to have a different insurance status shouldn't have access to worse quality care.
I'm so glad you said that, and I framed it and purposely teed you up to hit that, but it's interesting, that it does seem to be almost a caste system, and there needs to be more of a proactive approach that you're talking about. So I know that everybody appreciates that very much, and thank you for mentioning that. Now, those non-social factors that relate to the care, you mentioned transportation. What are some of the other? You mentioned loneliness. You mentioned food. Housing and other economic needs have a direct impact disproportionately on healthcare. How are you addressing those other very societal-driven issues, without using the word social determinants?
Yeah, I think there's a slippery slope. I think there's a slippery slope. I think we have to kind of look at the whole patient. But the healthcare system is not all things, right? And
right.
So I think we really run into a huge challenge here, where I think we can't be all things to all people, but at the same time, all things matter. And so where I think the opportunities really lie is in healthcare being a front door to other types of social support vehicles. Could the local housing agency have a connection to the healthcare system? Absolutely. But should the healthcare agency be the housing agency? I don't think so. And we have enough trouble within healthcare, driving patient safety, improving quality, driving affordability, that I don't think we should be, in the business of suddenly take on the business of providing housing, because I don't think we're good at the business that we have right now as it is. Well
said. Now, we're coming up on 5 minutes before the end of our time. What are the things that we didn't discuss that are top of mind on your end that you think you want to share around Caremore, just the healthcare system in general, for executive leaders from your perspective in healthcare?
One more time? What was the?
So we have 5 more minutes left. Are there any general thoughts or things that we missed during the course of our discussion that you'd like to touch upon to share with our audience around the healthcare industry in general, innovation, et cetera?
Yeah, I mean, I think we just need more courage. I think the problem, you alluded to it earlier in the conversation around the slow speed and the resistance. There's a focus on preserving status quo that really, I think, needs to change. I think we need to be progressive as an industry. We need to be early adopters, not late adopters of new technologies and innovation. And that's about people and leadership, nothing else. So I would just encourage folks to think about how they can exercise more courage in their everyday lives.
We hope that you enjoyed the show. Please feel free to share your comments at Craig.Ahrens, that's AHRENS, at Ankura, ANKURA.com.